All right, welcome to Thyroid Disease in the Eye. It is my great pleasure to introduce our speaker, Dr. Greg Caldwell. He's a graduate of Pennsylvania College of Optometry, and he also completed a one-year residency in primary care and ocular disease at the Eye Institute at PCO. He's a fellow of the American Academy of Optometry and a diplomate of the American Board of Optometry. I know he is a fellow of the Optometric Glaucoma Society. He currently works in Duncansville and Johnstown, Pennsylvania as an ocular disease consultant in private practice. His primary focus is the diagnosis and management of anterior and posterior segment ocular disease, and he's been a participant in multiple FDA investigations. He's lectured extensively throughout the country and over 12 other international countries. In 2010, he served as the president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 and 2016, and is president of the Blair Clearfield Association for the Blind. Greg has been an innovator and a leader in optometry for many years. He has been a supporter of organized optometry, been involved in organized optometry, been involved in academic optometry in training our colleagues both in optometry school and postgraduate. So it's my great privilege and pleasure to introduce our speaker, my personal friend and partner, Dr. Greg Caldwell. So Greg, take it away.
Thank you, sir. And thanks for that nice introduction. And everyone out there, this is probably one of the most gratifying lectures that I give, just for the reason that it always, about a day or two later, people will text me and say, you know what, I had a patient or two in that I knew exactly that this is what's going on and solving their mystery, their thyroid eye disease and the inflammatory part of this. So I love giving this lecture because this is probably the one that really in the office, when you have a red eye that's really not sure what's going on, will help you solve that red eye that you keep putting that steroid on in that inflammatory condition. So with that being said, let's jump in here. This is a pretty straightforward lecture. I'm going to blow through this one pretty quickly here. You can see that I lecture for many companies and received honorariums. I don't really have any financial interest in any of the companies that I talk about here tonight or in this lecture. I built this lecture, so it was not created by someone else. So thyroid.
Excuse me. And when everybody has any questions, please put them in the chat, and we will, at the appropriate intervals, break and answer those questions for you. So sorry about that, Greg. Please take over.
No worries. Thanks. That was a good little housekeeping. So thyroid disease and thyroid eye disease. I'm going to go really quick here, guys. I got a ton of information, but it's, if you got the questions or if I go over something quick, just put them in that chat box. So remember, the thyroid is an endocrine gland, and there's two major types of glands. Remember, endocrine and exocrine. The key with the endocrine system is that it is a ductless system. And the glands that are involved right here, the kind of the 8 that I have listed down below, using a ductless or in hormones and chemical messengers to circulate throughout the body. So exocrine means that you're using ducts to move, digestive enzymes and so on and so forth. So sweat glands, and the salivary gland is in the intestinal tract. That's all kind of ducted. Now, the one that I like to remember is the pancreas, because it's both exocrine by secreting the digestive enzymes, and the exocrine side, which we're all pretty familiar with glucagon and insulin regulating the blood glucose. So pancreas is both endocrine and exocrine. And when we talk about the thyroid, it's the largest gland in the body. It's butterfly shaped. I think we all know where it's located, just lies right below the skin and surface. And the main function is that it produces T3, T4, and calcium. So Joe, polling question, or I can do it right here. Polling question number 1, I had it launched and ready to go. Which patient comes into the office more? Is it a patient with diabetes or thyroid dysfunction? Or are they about the same?
And people are weighing in. We're already over 80%, going very quickly.
Yeah, you guys are awesome here. All right, perfect. Look at that, 94. Perfect, 30 seconds. Already. Good job, guys. So I'm just going to end it here. and share the results. And, diabetes, I think, wins the race most of the time because, and I do this live in the audience because I think we see more complications, or maybe after tonight, you maybe change your mind, but see more complications with diabetes than thyroid. But the group that answered 35% of the time there is about right. It's about 30 million people in the United States with diabetes, 30 million people with thyroid. So it's about equal when you see these patients in your office. Now, the normal thyroid function is you start up here in the hypothalamus with thyroid releasing. Remember, this is ductless. It talks to the anterior pituitary, creating thyroid stimulating, and then eventually making T3, T4. That's how the normal function works. This is the whole case. This is the whole lecture right here. This guy walks into my office and he says, hey, doc, I hear you're pretty good. You're this ocular disease consultant. These endocrinologists say to come see you. If you tell me I have a thyroid problem, then I'm going to just get up and walk out. So this is the whole crux of this lecture here. How can this guy here, who you can see with some obvious proptosis, why is his thyroid dysfunction being missed, or why is he having thyroid eye disease? So, I had to couch this to him a little bit. I just said, hey, you probably been tested pretty well. Your thyroid is not out of kilter. It's probably functioning just well, T3, T4. But, I think you do have some, complications coming from your, the thyroid or the mechanism behind, some of this. And he sat back and he said, okay, I'm interested. These guys keep barking up that tree, but you're kind of coming at it at a different angle. And that's what this is all about. So I want to ask everyone out here, thyroid dysfunction is, what is the most common cause of that? And I think I can launch this poll.
I just launched it, Greg.
Perfect. Thank you, Joe. And so is it cancer? Is it surgically induced? Is it medical toxicity or side effect? All of these can cause thyroid dysfunction. Where I'm going with this is all these patients, if a patient comes in with cancer, thyroid cancer, they're going to radiate it, maybe do some chemotherapy, maybe remove the thyroid, or it could be surgically removed or induced, or pregnancy can cause it. But what is the most common cause? And all these people are going to end up on Synthroid. So the key here is then, which ones are going to end up with the thyroid eye disease? And I'm able to see the results here. So I think, Joe, we could probably end that. I think people are pretty much nailing it. So if you share those, you'll see that you're right. Everyone out there, or most majority of the people, the number one cause of thyroid dysfunction is autoimmune. So with that being said, in autoimmune disease, the body produces what that attacks itself. And it's antibodies or immunoglobulins. You remember, I had a teacher whenever I was at PCO, and the teacher had a little nervous tick. And we used to sit in class, and how many times did the teacher do that? And we'd all walk out. I got 98 today and this and that. So my point is I'm going to say this word antibody tonight, and you're going to be sick and tired of hearing me say it. But that's really the basis behind thyroid eye disease. So polling question number 3 here is, and I kind of let the cat out of the bag, but what is the cause of thyroid eye disease? Is it the thyroid releasing hormone? Is it the thyroid stimulating? Is it T3, T4? Is it that whole cascade here? Is it the T3, T4, TSH, or the thyroid antibodies? So that's, we want to hone in on that. And then we're going to try and connect the dots here of how this thyroid, then how does it affect the eyes? And everyone's rolling in pretty good here. Look at that, cross that 90% barrier. So let me just share this right here with the audience. And everyone's right, or a majority's right here. 75% have said thyroid eye disease is caused by thyroid antibodies. And what I want to talk about tonight, the inflammatory thyroid eye disease is created by the antibodies. Now, for those who answer T3, T4, TSH, it does initially. So that's kind of a loaded question, I guess. But when I talk about the inflammatory side, that's where we're talking about these antibodies. For those out there, if you had to ask yourself, what is thyroid eye disease? What type of condition is it? Is it a cornea? Like there's cornea specialists, and then there's retinal docs, and then there's, anterior segment and glaucoma surgeons. Like, where does thyroid eye disease fit into this whole situation? And it's an orbital disease, right? That's what thyroid eye disease is. It's an orbital disease, and it gets stimulated by these antibodies, these thyroid stimulating and thyroid blocking antibodies, and there's a thyroid peroxidase. So it's these antibodies that are produced in this autoimmune, right? We all answered that the number one reason why thyroid eye disease occurs, or the number one cause of thyroid disease, is autoimmune. So the autoimmune part of the thyroid, these antibodies attack the orbit. The antibodies attack the thyroid. So thyroid stimulating here, you have an autoimmune. What I'm using here with these blue antibodies is that it's attacking the receptor. And since they're thyroid stimulating, it spits out T3, T4, which causes TSH to decrease. And that's what we were all taught was hyperthyroid. You can get thyroid blocking antibodies in this autoimmune disease, and they block and they hit the receptors, and then it blocks T3, T4. So it drops. Then it means it's a big negative feedback. So it starts pumping out TSH, but it's being blocked. But that's what we see in hypothyroid. This is what's happening at the thyroid gland when you're having this autoimmune disease. I'm just going to automate this whole slide here. So all these people here that come in are going to end up on Synthroid or some type of thyroid replacement, the hormone, the T3, T4. You have Graves on the hyper side, and then you have secondary causes, increased iodine, thyroid carcinoma. Over here, you have hypo, which is chronic acute thyroiditis, autoimmune thyroiditis, and you have these secondary causes like lithium and pregnancy and surgically induced. Every single person on here is going to end up with Synthroid. But which one of these people or patients are going to end up with the potential of thyroid eye disease? And it's really easy. It's these ones right here, the autoimmune part of it. So when someone comes into my office and I see Synthroid, one of my next questions is how did you end up on that Synthroid? Oh, doc, way back when I was hooked on French fries, I had tons of salt and I had excess iodine or, something to that effect. Or, I had a toxic adenoma and I had some surgery and some radiation to treat all that. That person there is not at really any high risk of thyroid eye disease. But if it's a person that comes in and says, yeah, I went through these crazy times and I have this autoimmune condition and my T3, T4, they were just really going crazy. And it took them a little while to figure out why I was getting all these hot flashes or why it's cold all the time. It's those autoimmune patients that are at risk for attacking the eye. And I'm just going to let the cat out of the bag now why that is. You get those antibodies that form. And those antibodies form to attack the receptors on the thyroid gland. And that's what creates all that havoc when the patient is going through that hyper or hypo period. But why is it that the orbits become involved? And here's the key. Here's the answer right here. Unfortunately, the orbital tissue, the fat, the muscles have receptors that look like thyroid tissue. So if your body is having an autoimmune reaction to create an antibody that goes and attacks the receptor of the thyroid, wherever receptors look like that, that's what it's going to attack. Unfortunately, the eye looks like thyroid tissue, so it's at high risk. That's why the secondary and tertiaries aren't really at high risk. It has to have the antibodies, right? There it is again. There's that word antibodies. I said that that I was going to say 100 times. So here on the slide, you see I have Graves' disease, and it's the hyperplasia of the thyroid gland, the infiltrative dermatopathy, right? The dermatopathy is usually around the ankles. For some reason, the skin around the ankles looks like thyroid tissue. So when those antibodies form, it can attack that and make that hypertrophy. And then the infiltrative ophthalmopathy, because the receptors inside the orbit, the muscle and fat, look like thyroid tissue. And we can see here women 7 times over men, and which then goes to the guy that was in my chair, right? They were thinking thyroid, but why wasn't he having the T3, T4, TSH problem? So here's Hashimoto's. I think we've all went to school and been beat to death on hypothyroid. And I'm always sensitive out there because I know that there's someone out here in this audience listening that has a thyroid condition, because it's very, very common, this autoimmune. So hopefully that will help maybe ease what's going on in your life with regarding this condition. So there's Hashimoto's, which is hypothyroid, and then there's autoimmune atrophic thyroiditis. All of these have antibodies involved, and all of these have the risk of creating thyroid eye disease. We all went to school and we were taught about what happens in hyperthyroid, lots of T3, T4, so nervousness, heat intolerance, sweating, palpitations. And then the opposite with hypo, right? The body's running slower, so cold, weakness, lethargy, monotone, bradycardia rather than tachycardia in the hyper. And then I like calling it thyroid eye disease, because Graves really should be if the patient is first diagnosed with hyper. Okay, then you can say that it's thyroid eye disease or Graves orbitopathy. But if they're hypo, it's really kind of a mix. I get we're kind of splitting hairs, but really Graves is for hyper. So I like thyroid eye disease, and you can see here thyroid associated orbitopathy. It reminds us again that this is an orbital disease. The structures inside the orbit look like thyroid tissue, and that's why these antibodies attack. So again, why is it so confusing? Because you can see thyroid eye disease if it's Graves, hyper, hypo, but it also is in evidence, like the guy sitting in my chair with no evidence of thyroid dysfunction. So, but my person that's sitting in the chair, guess what? His THS, his T3, T4 levels did drop eventually, and his blood work did get a little bit out of kilter, and he ended up on Synthroid to end that story for you. But I'll explain here why was he not being picked up on the T3, T4, or TSH. So why is it confusing? The eye symptoms usually occur at the same time of thyroid eye disease. However, they could be weeks, they could precede, months or weeks before, and they can show up much later. Now, anyone that is any autoimmune disease, I don't care whether it's thyroid or rheumatoid arthritis or lupus or the whole list of ankylosing spondylitis and all those conditions, the best thing you can do for those patients is tell them to quit putting those toxins in their body. They're already inflamed. Their body's having an abnormal inflammatory reaction. The last thing we want to do is create that inflammation by, having those other toxins come into play. So, while the eye disease might be brought on by thyroid dysfunction, successful treatment, right? Successful treatment of the gland doesn't do a darn thing, right? So if you get that T3, T4, TSH, Synthroid, and it happens all the time, right? Oh, Dr. Caldwell is an optometrist. He's saying you're having thyroid eye disease. Puh, your T3, your T4, TSH is perfectly normal. How can you be having thyroid eye disease? Huh. Okay, endocrinologist, primary care doc, let me teach you a little bit about this inflammatory condition. It's the antibodies that are attacking the eye. It has nothing to do with the T3, T4, TSH. So thyroid eye disease, commonly known as Graves' disease. Let me kind of step back before animating this slide. Let's say all 170 people here listening tonight, we were sitting here and we're all suffering from thyroid eye disease. So we're having a thyroid eye disease support group. So I asked everyone out there, hey, how many of here at the time of diagnosis were hyper? 80% of you would raise your hand. How many of you were hypo with the thyroid eye disease at your initial diagnosis? 10% would raise your hand. And then the other 10% would say, hey, I wasn't hyper or hypo. I was what was called, normal thyroid function or euthyroid. So again, now, what do I do in the office when patients come in and I see they're on Synthroid? Step number one, try to determine if it's an autoimmune disease that caused it or was it something else, the iodine, the secondary, the tertiary, because if it is, it's not involving antibodies. It's involving a second or tertiary mechanism. If it's autoimmune, they have the antibodies, and then try to determine if it was hypo, and that kind of puts you at the risk of who's going to get thyroid eye disease, right? So the autoimmune hyper is the 80% person that's at risk here. Now, I can tell you, I see a fair share of people with hypo and euthyroid come in, but when you're educating the patient and they want to know the risk of that, those are that what you can tell. You can say, hey, look, you might fall in that unlucky 10% because you were hypo at the time or you were euthyroid. Doesn't take you out of the woods. It just puts you at a much less risk of following. So when I follow patients and I do the Ludi or the Hertel on these patients, do I do it on every patient with Synthroid? No, I do it on the high risk patients, the autoimmune, and follow them to make sure that I'm following for them for their exophthalmos. So what causes the thyroid eye disease signs and symptoms? Initially, there's two phases to this. Initially, when the T3 and T4 levels, and that's why I said back in that survey that I could still see up here, when people answered thyroid releasing, thyroid stimulating, T3, T4, you do get some symptoms from that, some eye symptoms. But once the Synthroid kicks in and the endocrinologist gets everything under control, those eye symptoms go away. It's this congestive autoimmune, it's this inflammatory, which has an active plateau and resolution phase. That's the one that kind of tricks us as optometrists from time to time because of the soft tissue involvement that happens, right? So if you have a patient out there that you're continuing to put on, Lotamax or, the doctor in the bottle, Maxitrol, Tobradex, they're not allergic, they're not contact lens overwear, they don't look viral, it doesn't look like a bacterial, and they're on Synthroid, it could be that soft tissue involvement. And I'll show you some pictures coming up here shortly. So again, T3, T4 can create some issues, but that's not where I'm focusing on tonight. It's these antibodies that go and attack the orbit. So I want to move into some of that and what happens. But before I do that, let's talk about this euthyroid patient. How does that happen? Remember, these antibodies are attacking the receptors. What happens, and when you get these antibodies, there's always one that's kind of leading the race, whether it's thyroid stimulating, thyroid blocking, thyroid peroxidase. When you test these people, because you can do testing for that, the thyroid lab testing, you usually get one that wins the race. But what happens, remember, it's attacking the receptors. If you get the same amount as in this case here, the thyroid blocking and the thyroid stimulating, what happens if it's an equal amount hitting those receptors? Well, then you get a perfect amount of T3, T4, TSH. They never go to hyper or hypo, but the antibodies are now produced, which now can go and attack the orbit. So that's how someone that's euthyroid or normal. So that's what I'm showing here is that all these patients here have thyroid eye disease. And I want to point out that they're in different stages. These eyes look pretty white and quiet in the center. These are still a little red and inflamed. This is some active. Maybe this is in the resolution phase. There's different levels of thyroid eye disease, but it's these antibodies that are attacking the orbit. It could be the thyroid blocking, the thyroid stimulating, or it could be a mix of what's happening to this orbital disease. So here's a patient that comes into my office and she's like, "Hey doc, I hear, you're pretty good at some of this stuff." And, she's on and off of Lotamax. And she's like, no one can figure it out. They tell me I have dry eye. They're putting me on all this dry eye stuff. They want me to do these, these MIBO expressions, so on and so forth. But they tell me my oils look good. So I just said, okay, let me just run. It sounds like classic thyroid eye disease, just some soft tissue involvement. And here are the normal values. And so she was able to log in and she pulls up her TSH levels, and they were a little bit out of kilter. And then they started to settle down, and you could see she was on 50 micrograms of Synthroid. But this is where she comes in and finally sees me here. And I said, let's go get some thyroid antibody testing. So her thyroid globulin antibodies are less than 1, which is really normal. Here it is with the peroxidase. But look here, thyroid stimulating immunoglobulin, less than or equal to 1.3. She's 344, right? Her thyroid stimulating immunoglobulin are through the roof. And this is now what's attacking her orbit and creating the side effects. So what are those side effects that are out there? And you can order that blood test. So if you call up the hospital and you say you need some thyroid testing, make sure that, you're not just getting T3, T4, TSH. Call your laboratory up and just say, hey, look, do you have a thyroid antibody panel? We sure do. Do you want this? Do you want that? And then just make sure you're getting, at least thyroid stimulating blocking in the thyroid peroxidase when you're doing that. So the general symptoms, I think we all learned, are prominent eye stare, the pain, the lacrimation, the eyelid swelling, the double vision, photophobia. And then the biggest thing that we need to be concerned about is the optic nerve compression. We all learn NOSPECS. I like NOSPECS because it just reminds me of what can happen in this inflammatory orbital condition. No signs or symptoms. You can get some upper lid retraction. Soft tissue involvement is what you'll now start catching at the office this is the most gratifying part, is people will be like, oh yeah, I had this red eye come in and it was the soft tissue involvement. There's proptosis, the extraocular muscle involvement, cornea involvement when the eye starts to bulge out and the eyelids can't close, and then the sight loss from the compressive or ischemic optic neuropathy. And we all learned this, but it doesn't tell you, and the LEMO classification reminds us that lids, exophthalmos, muscle, and optic nerve can become involved. But it doesn't tell us what stage they're in, right? It just kind of reminds us what can be involved. So rarely are these grading systems used. You're trying to assess the inflammatory state of this thyroid eye disease. So I'm going to go through these pretty quickly here. Lid involvement, lid retraction, lid lag ophthalmos. All right, we saw these pictures a little bit before. You could see the upper lid retraction. Remember that the eyelid hits about 10 and 2 o'clock position. You can also see that this one's a little bit more active with some inflammation. The von Graefe sign, when you look down, the eyelid stays up. Lag ophthalmos, the eyes are bulging and the eyelids cannot, go around the globe. Soft tissue involvement, chemosis, conjunctival, periorbital edema. This here looks like a viral conjunctivitis. This patient's thyroid, this patient had orbital disease, thyroid orbital disease, soft tissue involvement. Her lab test was through the roof. She was diagnosed about a year and a half ago with this really bad hyperthyroid. And when we tested her thyroid antibodies, through the roof is what was happening with this patient. Now, we all probably can recognize this. This looks like SLK, superior limbic keratoconjunctivitis. Now, check this out. 65% is correlated with thyroid eye disease. Thyroid eye disease is an autoimmune disease. When it's not thyroid eye disease, what else can it be? Oh, rheumatoid arthritis and Sjogren's. What are rheumatoid arthritis and Sjogren's? They are autoimmune conditions. So when you see SLK, flip through your chart, I can tell you that most SLK patients come in, they're already on Synthroid. You're seeing now the soft tissue involvement from that, the antibodies that are attacking that orbit. If it's not, test them, they could be thyroid. And if that's not that, don't forget to rule out your rheumatological conditions. And the two listed there, the big ones are rheumatoid arthritis or Sjogren's, but it could be a whole bunch of the other rheumatological conditions. 12/7/2013 Optometric Management Symposium. We invited Dr. Andy Morgenstern down, and he was speaking, and he's talking about conjunctivitis, red eyes, and he just said to the audience, hey, if it's red, think TED, right? So don't forget, if you have this red eye, that it could be thyroid eye disease. And what I want you to kind of get in the grain of doing is, when you're checking and seeing that patient, you're looking at the history and the chief complaint, and you get down and you look and you see synthroid, maybe ask the patient, how did they get on that synthroid? Was it autoimmune? And then just keep in the back of your mind when you're examining them, could they be having some of the inflammatory orbital disease if it's from the autoimmune side? So here's the periorbital edema. Then we get the infiltrative orbitopathy, right? What do we do when we lift weights? We go and we lift weights, we tear muscle, create inflammation, the muscle hypertrophies. And this chronic inflammation and this lymphocytic infiltration and fibroblast proliferation is what causes the eyes to become proptosis or exophthalmos. You can see it could be unilateral. It can be bilateral. So, you might think that this is a tumor over here that's causing this, but this is thyroid eye disease that is a very asymmetric. And when you do the MRI, you can see here that you can see the muscles that are hypertrophy creating that that eye to be exophthalmos. And again, here's another patient, and look at the belly of this muscle right here. And you can see here that it's an asymmetric presentation with that patient. And again, here's the muscle right here. And then this came out of Elsevier 2005. And you can see all the lymphocytic infiltration that is caused from these antibodies. So exophthalmometry, some concerns here, 2 millimeters or more between the eyes, a measurement of 24 millimeters. But there are some racial differences here. White women and men versus black men and black women and men, and Asians. And you can see here, and that's why I give my slides out, or it's in the handout, what the upper limits are for these patients. So restrictive myopathy, secondary to edema or fibrosis of the extraocular muscle. The inferior rectus is the most common. I don't know why the inferior rectus. I love being able to try and connect the dots, but in the research, it always seems that the inferior rectus is the most common. There's 6 muscles. Why is it more prone to inflammation? I don't know that answer, but it occurs 30 to 50% of the patients. And now this is where some of the double vision comes from. We'll talk about IOP coming up here. But this is the patient here, maybe without the eye turn. But take a look at, I'm covering on my screen here, I'm covering this patient's left eye. And just take a look at this patient's right eye, minus the diplopia. This has got everything involved here. Soft tissue involvement, extraocular muscle involvement, diplopia. This is a classic, in a sense, thyroid eye disease patient, orbital disease. But take away the eye turn, maybe that kind of gives it away. If you just look at that right eye, that might help you out with some of the patients that come in and you're trying to scratch your head. Why is this chronic red eye? Flip back in the chart or flip back in your electronic health record and see if the patient is taking, Synthroid or any of those types of medication. And then you can get corneal exposure. And then the key here is optic neuropathy. This affects 5% of the patients. This is really the biggest thing that we need to worry about. As you can see here, these arrows are pointing, and Dr. Salka always says, if you're going to get an MRI, always invest, pay a little bit more to get the one that has the arrows on it. It really helps you find the pathology. But you can see here that this muscle's involved, but when you get back here, what is running through there? The optic nerve, and that puts the optic nerve at risk for compression, ischemic, or in a sense, a toxic type of neuropathy from this condition. So when it comes to treatment, it really comes down to now, are they in the active phase, which is the inflammatory phase, or are they now in the resolution phase? Because if they're in the inflammatory phase, the last thing you want to do is maybe send them for surgery. You might be doing things more like what we're going to learn about here is Tepezza or Teprotumumab, which was just released last year at the worst time during COVID that they couldn't get out and let everyone know. Or you might be doing steroids, or you could be doing things. Oops, someone must be off of. There we go. So we have someone that we want to put on steroids, or we want to wait till they're in the resolution phase or the plateau phase to make sure that we can do we can do surgery at that time to help the patient, but we don't want to induce any more inflammation. So are
Hey,
they
Greg,
in the inflammatory phase, or are they in the passive phase? Dr. Safra.
I just want to interrupt you with a question in our chat. Most hyperthyroid patients are not on Synthroid. Is that correct?
Most are eventually going to be on Synthroid. Obviously, at the time when they're going through the phase, and that's especially if they're autoimmune. And the case is that as they're going through that process of the receptors attacking, and they're trying to use Synthroid again to slow down the TSH. That's where the endocrinologist comes in. They're just trying to manage the TSH. So yes, they can be on Synthroid, whether they're hypo, or euthyroid, I guess, in a sense, once they start going out of kilter for the euthyroid.
And Greg, just to underscore something you had said about the vision loss and the compressive neuropathy, when most eye doctors hear about compressive neuropathy, they worry or they think about missing a tumor. But the number one cause of compressive neuropathy is thyroid eye disease. It's Graves' disease. That's the number one cause of compressive neuropathy.
So Joe, that's one of Joe's specialties for you guys that are out there. Joe is big into neuro. He started a few, what is it at the academy, Joe? The neuro section, yes. And you're a fellow in the neuro, and so that's a great pearl there coming from someone that knows neuropathies. That can you just repeat that for the audience? That compressive is caused by
is more caused by Graves' disease. Graves' disease is the number one cause of compressive optic neuropathy, not tumors. But if you're looking for a tumor, as Greg has showed with the images, the radiologist will find what the ultimate cause is.
So let's go through. I'm going to try and land this in about 11 minutes. So I'm going to go through this pretty quickly. The treatment, right? It's inflammation. It's active versus passive. So when it's, in the active phase, you can do things palliative, anti-inflammatories, prism for the double vision, steroids, and that could be oral or periocular injections or IV, orbital radiation, radiotherapy. In the active phase, if you think that compressive lesion's going to damage that optic nerve, and you can then do fat and bone decompression. But remember, always counsel, beg, plead, grovel. And I know it's easier said than done. Get the patients into smoking cessation programs because those toxins really inflame the autoimmune side of it. So paradigms are shifting now that we understand this disease a little bit better and the antibodies. And, we want to treat these inflamed eyes with maybe moisture goggles and taping them taping their eyelids closed at night, or using steroids. And then in the passive phase, getting into surgery. And this person came in, and you can see these eyes are perfectly white and quiet. It's been going on for a while. And in the upper picture, the patient said, "Hey doc, I do have thyroid eye disease and not a darn thing I can do about it." And I said, "Well, I kind of disagree. Let's get you down to my lid specialist down towards Pittsburgh." And you can see that they went in and removed some of that scar tissue and did readjusted that lid there. And now the patient doesn't look as obvious as having thyroid eye disease. And then I showed you these earlier, the periorbital edema. You can lubricate them, oral steroids, things like Restasis, Xiidra, all these immunomodulator type of medications that are out there. You can move into oral steroids, topical steroids. that are out there to control the inflammation. And then coming down to these patients here, I always try to give clinical pearls out. When you're looking for pharmaceuticals, try and have a pharmacist that has, atropine to treat that nasty iritis and have Zirgan to treat that central dendrite. My advice is know where your orbital disease consultant is. They're usually in the bigger cities. We all know where our retina docs are and our go-to cornea guy and cataract guy. But what happens if this patient comes in or this patient comes in and you think that they're in for compressive? You're going to want to get them to an orbital disease consultant specialist so that they can work their magic and save that optic nerve. With restrictive myopathy, you can certainly, in the active phase, use prisms and maybe botulinum injections. I've never seen it done. It's in the literature all the time, but use prisms. But then whenever they go to the burnout phase, the resolution phase, you might get them to an adult strabismus person. We all know how to handle an abrasion. We talked about, the optic neuropathy a little bit. You could use in the active phase, methylprednisolone. You might use radiotherapy. In the quiet phase, resolution phase, you might be doing an orbital decompression. And the doc that I used down in Pittsburgh sent this to me, and I just was blown away by a 2-wall decompression. We always start superior, it's the thickest bone, and then nasal. We all know that the inferior floor blows out, so it's the last one that they go for. It's the thinnest, and then temporal. But look at this. You can get 3 to 16 millimeters of retro displacement, and that's just by doing bone removal, not to mention you can mix that up with bone and fat removal, and that's why you want to know where your orbital disease specialists are. So polling question number 4 here is, true or false, as an optometrist, we can help someone with his or her depression or anxiety? True or false? Can we help someone out? And I think the overwhelming number is everyone sees where I'm going with this. Thanks, everyone. Look at that. 20 seconds, Joe. I think that's a record. Got them to 91%. Thank you, everyone, for paying attention and doing that poll. And it is true. Here's a patient here that comes in and she's got thyroid eye disease. I said, let's get you down here to my lid specialist. She was on antidepressant anxiety meds here. She's not here. And I think this next statement, and I lost the reference. I need to get the reference for it. I had it referenced down here, but I lost it. But when you tell someone they have facial disfigurement, it's equivalent to the diagnosis of cancer and AIDS. So check out this person coming in. You could see the upper lid retraction. You could see the soft tissue involvement. And this person's sitting in your office, and you're not going to say it this way, but they say, hey, doc, why are my eyes like this? And you go, hey, your facial disfigurement is from your thyroid eye disease. When you're telling them that this is happening, it's equivalent when they have facial disfigurement that you told them cancer or AIDS. So when you have patients come in, wait for them to get to that resolution phase and send them off to a surgical consults, and you can help these patients out there. And I think that's one of the funnest parts about what I do when I see these patients coming in and you see that they have a big muscle like this, and you can send them for orbital decompression or fat decompression. So in the last 5 minutes here, what I want to cover is a few things, and then I want to get into the treatments, one newer treatment. So a lot of people ask me like, hey, are the patient at risk? Well, they always talk about IOP and thyroid eye disease. What is it? So if a patient comes in and they're on Synthroid, they have autoimmune, I don't think glaucoma suspect, but there's things that can happen that can influence the IOPs. This amount of orbital disease going on in these 2 patients are probably going to influence the IOP more than this patient. Or this IOP is probably going to be a little bit more influenced in this left eye than over here in this right eye. And this patient's IOPs, and you can see here with the restrictive myopathy, this eye pulling down. So IOPs are influenced by thyroid eye disease, but this is the reason how they can happen. I put this in here for completeness, all the different tests. I'm not going to read this over. I try to make all my stuff a reference. I want to end in the last 4 minutes with this patient. This patient came in almost a year too early, right? And you're going to see why I say that. February 25th, my technician diagnosed this. This came from a ODMD practice. They're treating him for his dry eye. Can't figure it out, right? Male, not female, 7-1, older, not younger. Classic thyroid eye disease right here. This gentleman, I ran his blood work, his thyroid stimulating immunoglobulin through the roof. And you can see here he has even a muscle entrapment or muscle involvement. You can see here his eyes not moving out as much, worse in the left eye than the right eye. So I sent them, and I'll tell you where I send a lot of these guys like this to the rheumatologist, because who's better at treating inflammation? And we started him on some IVs to try and get his eyes quieted down. And you can see here he started to improve. Look at the much improvement here. I should put up the other picture, but we can go back real quick. You could see him here, how bad he was. And then we started treating him and got him on some right medications. But I didn't like what was going on with this left eye. So we ended up getting him to an orbital disease specialist down in Pittsburgh. And you can see 4 days he improved nicely. Look at this a month later. You can see all the steroids he's on. Look at the biggest side effect, that moon face that he has, right? He didn't have that before, and that's a side effect of here. So at this point, I really wasn't liking, he was still having double vision. So I wanted to see if we can get him down to an orbital disease specialist to see if they could free it up. And he did. We freed him up, and he's doing a lot better. I need to get some after pictures. You can still see here on April 22nd, he's much improved with his thyroid eye disease, but in the orbital side of it. We're going to skip the polling question because I want to finish up on time in the next 2 or 3 minutes here. Is that I saw this in 2018. Thyroid eye disease therapy shows promise, that there's this Teprotumumab, right? It's a monoclonal antibody. It's a biologic. It's going to go after the insulin, I think, growth factor number 1 here. It's coming up here. It was by Horizon. So, and that's what happened. Yes, insulin-like growth factor number 1. How is an insulin-like growth factor number 1 going to help out with thyroid eye disease? Biologic. This one is through a Chinese hamster ovary. And what they've done is they've created an IGF-1 receptor inhibitor, which is, again, a monoclonal antibody. That's what biologics do. They target. And the PDUFA date that's when it was coming out. Look at that, March of 2020. It was approved in early 2020, right when COVID was hitting. Let me just show you what's going on. I love this picture right here. This is the orbital disease. It takes 2 parts to get, this is like a muscle or a fat that's going to now become inflamed. You can see here, it says an orbital fibroblast. There's 2 parts. See right here, thyroid stimulating releasing right here. This thyroid antibodies attacking here. And this insulin-like growth factor comes in. And when these 2 things hit, now you've got the cascade of thyroid eye disease. And what happens is Tepezza, Teprotumumab, this monoclonal antibody comes in and blocks half of that. And by this just targeting this receptor, it cuts back on the thyroid eye disease. There were studies done on it, and it looked at proptosis, diplopia, and the quality of score for these patients, and they all improved. So I wanted just everyone to be aware of Teprotumumab. It's done with an infusion. You have to, at least in Pennsylvania, I can call the endocrinologist up, tell them that they're having thyroid eye disease, and then we find an infusion site that can do this. So the infusion reactions, they're very mild. Remember, it's insulin like growth factor. So there are some hyper, which is okay. You die from hypo, but you don't die from hyperglycemia, but you can create some hyperglycemia when they're getting infused. So really the key is, if you think you have someone that can benefit, what I would recommend, go to Horizon's website. You want to just hit contact us, type in your question, and they might be able to find you someone in the area that can do the infusion for you. Last slide right here are the signs of thyroid eye disease. I was just being a geek one day, writing them all down, decided to put them on a slide. If you guys ever want to play Trivial Pursuit of thyroid eye disease, there are all the different signs that have been identified. So with that being said, I think like Delta, I think we started at 8:06. There's 8:56. So Joe, any questions? And I'll take a breath right now.
Well, questions with clarification, but you when you said Trivial Pursuit, I think the game you'd be playing would be very Trivial Pursuit on that one. So with that, Greg, I thought that was a fantastic lecture. I know that that thyroid disease is really your Sergeant Pepper's. So I thought you did a fantastic job with that.
Thanks. Yeah, it's probably like I said at the beginning, the most gratifying because after I do this, I usually get 5 or 6 throughout the next course of the month. People saying, "Hey, you helped me solve that, and I got the blood work. Thank you for doing that." The patient thanks you. I thank you. So it's probably the one that I truly love giving the most because it does solve a lot of mysteries that's out there. So